and Noriko.
Good morning, good afternoon to everybody. My name is Noriko. Thank you for joining our webinar today. I'd like to be able to go through some of our research that we've been doing for the last while with regards to hemorrhagic stroke, and we work with animal models, with rat models, and primarily hemorrhagic stroke itself. So just to give a quick background in terms of hemorrhagic stroke development altogether, it's of all the stroke subtypes that we have, intracerebral hemorrhages has actually the highest mortality rate, as you may be able to guess, and it approaches about 42% in the first month or so. Now, when we take a look at stroke, about 80% of stroke is attributed to hemorrhagic stroke, with 20% being attributed to hemorrhagic, and treatment modalities are primarily for ischemic stroke, with not much modalities as available for hemorrhagic stroke itself. And what's dangerous is the fact that with hemorrhagic stroke, the incidence is actually growing, and you could see that more strokes actually turn hemorrhagic with the fact that with improved imaging and detection, you can actually detect up to 40% of the strokes being hemorrhagic itself. Hypertension is a major risk factor for hemorrhagic stroke itself, and long-term survival is actually complicated because rebleeding and secondary hemorrhage formation prevents proper healing itself. So what is important is to be able to figure out what hemorrhagic stroke can actually lead from, what mechanisms of hemorrhagic stroke is in terms of its development. And for our interest, we've linked it to the fact that there are cerebrovascular events that occur that tends to lead to brain bleeds altogether. And the question being is that, can we increase survival in those cases? Because treatment options are very limited when it comes to hemorrhagic stroke in our people. Our talk section is going to be divided into figuring out what the functional changes in the brain vessels or the cerebrovascular vessels are, and we've linked it to what we call autoregulation and its function. And we study this using different types of animal models. We will define also the molecular mechanisms from there that's associated with the loss of cerebrovascular function. And from there, we're going to take a look at the potential treatment options that are available as well. So taking a look at the different rat models and animal models in terms of rodents, we actually use what we call a stroke-prone spontaneously hypertensive rat model. And these models actually have been developed, I believe, in Japan in the first place. And from the Kyoto Wistar stroke-prone model is called stroke-prone spontaneously hypertensive rat model. So we don't induce stroke by themselves, really. They are stroke-prone in terms of its genetics. But if we feed them what we call a Japanese style diet with 4% sodium chloride from the time of weaning, which is about 5 weeks, we can actually figure out when actually they do stroke. So at 10 weeks of age, we call them at pre-stroke, which means that really at about 9 to 10 weeks of age, what we define as before stroke symptoms, their blood pressure actually does increase. They start increasing, and we'll see what the blood pressures are when they start increasing. And around the 12 weeks of age time, about between 10 to 12 weeks of age, is the timeline in which they actually show signs and symptoms of stroke, which is seizure, lethargy, and immobility. And around 13 to 15 weeks of age is when, if they're untreated, they develop, the actual hemorrhages are evident when we sample the animals, and the mortality is increased from 13 to 15 weeks, and it is quite fatal. Now, what's interesting is that, so within 2 weeks of onset of stroke is when we actually see the mortality increase. And these particular aspects of the stroke are shown with an increase in systolic blood pressure that we see at 10 weeks. There's a development of a leaky blood-brain barrier. We'll take a look at that. And the seizures themselves, and there's severe lethargy and immobility. When we take a look at a video of that, you could actually you could actually see the difference now in terms of what a pre-stroke animal looks like. So a pre-stroke rats are little nice rats. You could see that at 10 weeks of age, they're very healthy, they're well groomed, they're looking around, they're very curious, they're seeing what food and what we're doing with them here. So you could see the fact that the faces are nice and lean, it's not puffy, the eyes are alert, they're curious. When they get stroke symptoms, you'll be able to see that there's actually sometimes this twitching aspect of it. So I apologize if it is a bit disturbing. They get these twitching aspects in which, because of the actual neurological symptoms, they actually start twitching. They do sometimes get loss of movement from their hind legs, and then they get this hunchback and muffled coat look that you see, with their eyes being almost shut, a little bit of bleed, porphyrin staining around their eyes, which is a sign of pain. It's almost like when you get sick and you have a cold and a flu and you can't actually feel anything, you just want to curl into a ball and sleep. That's the kind of symptoms that are associated with the post-stroke animals. When we see these signs and strokes, which we've actually been watching, we've been studying for the last 10 years for me, 15 years for myself, you could actually tell that they have developed stroke. Those are the times in which we call them a post-stroke animal. So as you see here, when we actually have a pre-stroke and post-stroke animal, our questions in our head is, what is occurring into the brain that is causing these stroke symptoms itself? The main thing being, of course, it's going to be a blood-brain barrier disruption and brain edema that occurs with stroke. So here we have an example of a pre-stroke animal. So before stroke symptoms, when we've isolated the brain, and could see that the fresh brain is nicely vascularized, the septum is nice and straight, the two hemispheres are actually nice and well formed. The brain, just by looking at it, looks very healthy. When we actually infuse Evans blue dye, now Evans blue dye itself, it binds to plasma albumin, and it's a very good mechanism for us to be able to see if there's a Evans blue dye and albumin extravasation from the vessels because of the blood-brain barrier disruption. You actually end up seeing pockets of Evans blue dye itself on the brain itself. And we see that with hypertensive encephalopathy and cerebral hemorrhages. And when we take a look at here our post-stroke animals, you could almost see the fact that there's a distorted septum there, with our hemispheres actually being very distorted. I mean, the size of the two hemispheres are different. You could see that there's severe edema that has occurred even with our fresh brains itself, and major cerebral hemorrhages that are actually seen there. The brain itself is very watery, and when we infuse the Evans blue dye itself, you could see pockets of Evans blue extravasation here, which is a sign of blood-brain barrier disruption. And altogether, what we end up having is a watery brain, a sick brain, and it is associated with our stroke model itself. When we take a look at the systolic blood pressures themselves, what's interesting is that normal systolic blood pressure in a stroke-prone model or any kind of rodent, it tends to be between 130 to 150 millimeters mercury systolic. In our animals, when they're untreated with the stroke-prone spontaneously hypertensive rats, the blood pressures actually rise from about 180 to almost 300 sometimes. We've seen 300, but it goes up to about 250, 260, 270 millimeters mercury in terms of systolic blood pressure. Now, it's systemic systolic blood pressure. And often in a healthy animal, what the brain vessels do, the middle cerebral arteries do, its function is to be able to maintain a steady blood flow to the brain, even though the blood pressure in the body is actually rising. Okay, so then there's actually physiological problems that's occurring with the cerebral vasculature that prevents that. And what we call is that in that case, it's a loss of autoregulation of the middle cerebral artery. So those arteries are one of the 2 or 3 arteries in the body that undergo autoregulation to be able to maintain a constant blood flow to the certain types of organs, kidney being one of them, the renal arteries being one of them, right? So middle cerebral arteries maintain a steady blood pressure to the brain, when the systemic blood pressure increases. What we're finding is that in our studies with the physiological problems associated with these models, hemorrhagic stroke, is the fact that there's actually vitamin deficiencies that seems to be occurring for in terms of biochemistry, in which that's associated with the diet itself. Okay, we've actually seen also that there's a loss of the ability of the middle cerebral artery to respond to pressure. So that's part of that autoregulation that the middle cerebral artery does. So that there's a loss of what we call pressure-dependent constriction that's occurring in the vessels. And that is associated with the vascular smooth muscle and endothelial functions of the middle cerebral arteries being lost as well. And we'll go through all of that in turn right now. So one of the things that we're talking about is this loss of cerebral blood flow autoregulation, such RSPs after stroke. So what that means is that in a normal body, a normal middle cerebral artery function, as the systemic blood pressure rises here, you could see that this is the mean blood pressure in the body. The blood flow to that is maintained by the middle cerebral artery is relatively kept constant. It doesn't rise as much. It doesn't really correlate with the systemic blood pressure here. So there is somewhat of a rise, but it doesn't rise as much. There's maintenance of the cerebral blood flow so that you don't get overflow of the blood to the brain itself until it reaches, the systemic blood pressure reaches about 220 or so. And then we have the break here. So that this, what I used to call, what we used to call actually a hockey stick figure in terms of stroke, that is actually lost here in after stroke itself. So you could see that the blood pressure, as the blood pressure rises in animals that have had shown stroke symptoms, and we're looking at the cerebral blood flow, with an increase in mean blood pressure, there's an increase in cerebral blood flow. So that shouldn't really be occurring in a healthy animal. And that's a function of the middle cerebral artery to maintain what we call autoregulation into the brain itself. One of the questions was, well, what is important in terms of vascular function that may be causing this? And one of my questions recently has been the function of vitamin B12. And we took a look at the function of vitamin B12, which affects major biochemical function, because vitamin B12 or cobalamin is an important micronutrient that's required for two critical enzymes, methionine synthase and methylmalonyl-CoA mutase. So basically, deficiency in B12 is associated with the signs and symptoms that we tend to see with stroke and vascular loss of vascular function, which would be pain, tingling, vascular neurological problems that are associated with the stroke symptoms that we tend to see. And what's interesting is that we have a deficiency likely from B12 when that's associated with the diet, which was a concern of ours because a North American diet tends to be a high salt diet content, could be associated with the fact that there's a lack of B12 that maintains physiological function and prevents stroke. That high salt diet content is actually preventing a nutrient availability to be able to, which then leads to more stroke symptoms itself. And sure enough, in our animal models, before and after stroke, regardless of whether they're before and after stroke, the level of B12 is actually much lower if the animal was on a high salt diet. And it correlated with the metabolite that is linked with a decreasing B12 levels as well. So methylmalonic acid, MMA levels were higher in correlation with the lower B12 levels with the high salt diet itself as well. So this was something interesting for us to be able to build on in terms of nutritional deficiency that may lead to the stroke symptoms that we see in animals itself. We were talking about autoregulation, the fact that the vessels themselves lose the function of being able to regulate blood flow to the brain. And the mechanism of that is the middle cerebral artery's ability to contract. And that was something that we've been taking a look at for a while now, which is to look at the vascular function in terms of how it regulates protein kinase C, PKC function, intracellular calcium release function, endothelial function potentially, as well as response to luminal pressure. So when we studied the ability of the middle cerebral artery to constrict to PKC activation, we saw and took a look at the decrease in lumen diameter. So when you activate PKC, if the vessel is healthy, if the MCA is healthy, it should actually constrict and decrease lumen diameter. And in our pre-stroke animals, we see that there's an increase in lumen diameter in response to PKC activation. And in post-stroke, that function is actually lost as well. So here is one evidence that the middle cerebral artery function itself is lost in terms of its response to PKC. When we take a look at the ability of the MCA to constrict to sarcoplasmic calcium release, which is a response in this case to vasopressin, we took a look at, we see a very similar result in the sense that the ability of the vessels to decrease and constrict in response to sarcoplasmic calcium release is also lost in the middle cerebral arteries after stroke itself. When you actually took a look at how the middle cerebral artery responds to 100 millimeter mercury pressure step, that means that when you increase the luminal pressure to 100 millimeters mercury, does the vessel respond and constrict to maintain a proper flow? That's how it autoregulates. Is that mechanism available or is present before after stroke? We see that particular ability of the vessels to constrict to pressure in the response to pressure is actually lost again. So that when you increase the vessel pressure to 100 millimeters mercury, the MC actually goes like it actually gets constricted if it's healthy for about 6 or 7 minutes or so. And that is a response of the MCA to constrict to 100 millimeter pressure step. That response is actually lost in post-stroke, which was really interesting. All of that also to be able to also see, well, these are vascular smooth muscle cell functions that we're looking at. What about endothelial functions? We took a look at the ability of the middle cerebral artery then to react to what we call bradykinin stimulation. Bradykinin stimulation, which is an endothelial vasodilator. We see that the ability of the vessel now to dilate to bradykinin, so endothelial function in this case, it's also lost here. And there's also the nitric oxide function, which was the next question that we took a look at. And here was the ability of the MCA to react to nitric oxide synthase inhibition in both endothelial and non-endothelial NOS function. And we saw that really the way that you actually be able to figure out whether NOS is working or not is to add L-name, which is a NOS inhibitor, and see the fact that if you inhibit NOS, there should be actually constriction in a healthy animal. And that's what we see with a pre-stroke animal. The endothelial function is likely there because before stroke, the vessel is able to respond to L-name, which is a NOS inhibitor, and constrict, whereas after stroke, it is lost. We try to take a look at whether non-endothelial NOS function is there by denuding the vessels and looking at the loss in its response to NOS inhibition. We see that response to NOS inhibition is also lost in the non-endothelial NOS function itself. So the ability of the middle cerebral artery to respond to L-name inhibition of NOS after 100 millimeter mercury pressure step is actually lost in our post-stroke animals. And these responses are actually not due to the inability for the vessel to dilate in response to nitric oxide or any nitric oxide scavenging, nitric oxide synthase substrate or cofactor limitations. So all of this was work that was done by Smida and myself, John Smida and myself, and it was published in 2017. Our next question now, before I move forward a little bit, our next question really we've been looking at this with the stroke prone spontaneously hypertensive rats. So this animal is already genetically set to be able to develop spontaneous stroke. But when we take a look at epidemiological studies as well, it's not just that we don't know what populations really develops hemorrhagic stroke. That was a question that went through our minds. And you could take a look at the fact that in different disease states, you know that hypertension is actually cardiovascular disorders is one of the main ones in some of the other diseases that you don't really link to. And autoimmune disease is one of them, in which patients that have rheumatoid arthritis actually have the highest incidence of stroke, actually, hypertension and stroke and cerebrovascular events. And this was something of a mystery, of a conundrum for us to be able to figure out. There's a strong incidence of cerebrovascular events that occur in autoimmune diseases. And what's interesting is that autoimmune conditions alone are an independent risk factor for stroke, regardless of any other diseases that are present. And our thought process was, yes, well, there's secondary vasculitis is occurring that's associated with inflammatory mediators that's likely involved. And usually inflammation is associated with ischemic stroke, but really not hemorrhagic stroke. But the evidence in the literature with epidemiology was showing that hemorrhagic stroke is also increased in terms of its incidence. So our thought process is we're seeing in our animal models of just stroke animal models, there's changes in the cerebrovasculature with just the genetically prone stroking animals. There's changes in the cerebrovasculature that causes that intracerebral hemorrhages and hemorrhagic stroke. Can we actually see very similar changes in the cerebrovasculature in animals or in conditions that have systemic inflammation, have hypertension, and possibly see hemorrhage occurring in those? And to be able to do something like that, we actually need an animal model to this, animal model that reflects this. So really, we need to be able to study the degree of cerebrovascular damage that's actually leading to this, to stroke, using a very appropriate animal model that really didn't exist. So based on our evidence from our SHRSP model, which is our genetically prone stroking model, we can actually postulate that there's going to be changes to the cerebrovasculature that will occur in arthritis, in a systemic inflammatory condition, and lead to changes in responses to a pressure that's already there, hypertension, potentially that leads to stroke. So there's damage that's occurring to the middle cerebral artery, potential to the vascular smooth muscle cells, potential to the endothelium that causes the loss of pressure-dependent constriction and the vasogenic response. And based on some of the aspects of our vitamin B12 studies that we took a look at, there's potentially diet-induced changes in the severity of inflammation and the damage in the middle cerebral arteries themselves. So the questions that we had then to link arthritis and cerebrovascular events is what is happening in our arthritic models, in arthritis, that predisposes the body to be more prone to having a hemorrhagic stroke. And then from there, can we study this in terms of what is happening in arthritic condition that leads to intracerebral hemorrhages and strokes themselves? And as I mentioned, there is no really animal model. There's no mechanism really to be able to study this in humans. We cannot approach an arthritic patient and say, you know, I think you might be prone to stroke. Can I take a look at your brain right now to be able to do this? At least I can't. I don't have the means. I'm not a clinician, unfortunately, to be able to go into that. But I do, and especially molecular mechanisms and physiological mechanisms is difficult. So then what is available to me, however, is to be able to create a multi-disease model. So what I did was go back into my animals, into my rodents, and develop an animal model that is spontaneously hypertensive. However, it's stroke resistant. So this is the key here. These spontaneously hypertensive rats that you see here, at a certain age, even if a longer age, about 5 to 7 months is what we used, which is reflective of middle age sort of thing in humans. We took these spontaneously hypertensive rats that are stroke resistant. We divided them in a group in which they got a high salt diet. So we're trying to take a look at the diet-induced changes as well as a regular diet. And we injected them with a very sort of a mild form of arthritis. So we cause a monoarthritis. Excuse me. I injected them with an intradermal injection of complete Freud's adjuvant just in one paw. So monoarthritis. This is almost akin to if you step on a nail and you get an infection in your paw. It's almost like that, but it does cause arthritic damage in the joints themselves in that particular paw. So it's a monoarthritis itself. We monitored them for 21 days. And we did all sorts of tests, physical tests on the animals themselves to measure the degree of inflammation, systemic as well as paw inflammation and such. And then from there, when we took sampling time, we isolate the vessels, cerebrovasculature, and we put them on the living systems instrumentation, the arteriomyograph that we got from living systems. And we studied the mechanisms of its of how the middle cerebral artery responds to pressure and to different types of vascular smooth muscle endothelial manipulations themselves. Okay, now moving forward, now we again recall that we had the SHRSP model or stroke prone model as our basis to be able to compare. So when we take a look at the brains of our spontaneous hypertensive animals, just to give a background again. So these are SHRSP models on the high salt diet before stroke with EB infusion and after stroke with EB infusion. You could see that there's EB extravasation here, again, distorted septum. It's very severe. So this is a genetic model itself. We were not sure whether we could recapitulate this with our animal models itself. So here's our stroke resistant model, and on the high salt diet, there are control animals that were given saline injections. You could see that the brain themselves, even with the EB infusion, there's nothing, it looks very healthy. It is, there's no distorted septum. The left and right hemispheres look very healthy. It's very well vascularized. But what's interesting is that when we give them the high salt diet and they're given complete Freud's adjuvant, they're given monoarthritis. So we call these the hypertensive arthritic models on a high salt diet. After 21 days of inflammation, you actually saw EB extravasation. We actually got intracerebral hemorrhages. There is decrease in vascularization. It's nothing as severe as our SHRSP models, but it is there. And you could actually see distorted septum. The animals themselves don't look too healthy itself. They did not show physical signs and symptoms of seizure. However, their brains did show intracerebral hemorrhages, which was very exciting for us. We were not sure whether the regular diet, whether diet itself made a difference. And what's interesting is that with our regular diet itself, if they had arthritis, if they were given arthritic treatment, we actually did also get cerebral hemorrhages there as well. So that was something. It's not as severe, of course, with the high salt diet, as you can see, but it was there. We saw what we call pinpoint hemorrhages here. So these are cerebral hemorrhages here, but these are pinpoint hemorrhages that we did see in terms of Evans blue extravasation. The question being is that something in the systemic inflammatory condition is causing potentially cerebrovascular damage and neuroinflammation. So we asked the question, is there neuroinflammation occurring in our animal brains? And we did immunohistochemical staining. We stained for microglia, and we took a look at for reactive astrogliosis. Both of them indications when they're increased. It's an indication of scarring, brain damage, and neuroinflammation. We saw that with the regular diet, we don't see too much activation of the microglia, some activation and some indication of astrogliosis. And our H&E stains are showing that there's aspects of cell vacuolations and cell edema and neurodegeneration, but not that significant with our monoarthritic animals, compared to our saline animals, in which we don't see too much signs of activation of microglia or astrogliosis, and definitely no signs in terms of tissue damage in our H&E stains with the regular diet. But there is some indications of it. But what's interesting is that if the animals were on a high salt diet, there was a significant increase of astrogliosis and when they were actually given inflammatory insult, systemic inflammatory insult in form of neuroinflammation. In form of monoarthritis. There was definitely activated microglia as we actually took a look at the shape and the size of the microglia itself, and did a quantification of that. And the H&E stains themselves actually showed a lot more cell evacuations, neurodegeneration, and cell edema upon analysis. What's interesting is that the high salt diet by itself actually increased microglia activation and gliosis as well, astrogliosis as well. Not as severe as the ones that had monoarthritis, but it was evident. And quantification of that shows us that high salt diet in combination with monoarthritis actually caused more significant neuroinflammatory damage as compared to the regular diets, monoarthritic animals. And high salt diet by itself seemed to cause more neural damage as well. Okay, may not have caused that much microglia and astrocyte activation, but we did see more neural damage with the high salt diet itself. So how does that actually translate into vascular function and middle cerebral artery function? We did very similar work with the arteriomyograph as we did with the stroke-prone animal model. We took a look at the pressure-dependent constriction in our regular diet, saline, this is our regular diet control group with regular diet monoarthritic group, our high salt diet saline group versus our high salt diet monoarthritic group. And we saw that the ability of the vessels to actually constrict to middle cerebral artery was lost compared to the regular diet for both high salt and monoarthritic groups itself. And it's very reflective of what we saw in our SHRSP models themselves. When we took a look at the PKC activation now, this is the response to PKC activation in our regular and high salt diet fed monoarthritic groups and saline groups. We saw that causing inflammation systemically actually decreased the cerebral response to PKC activation, the middle cerebral artery response to PKC activation. And so that means that this the system, in terms of signaling mechanisms, the system in the PKC activation seems to be affected with systemic inflammation. So there is cerebral vascular damage that's occurring when you actually have a systemic inflammatory condition akin to monoarthritis in this case, as seen in our animal monoarthritis system. So the next question was, does intracellular calcium release have an effect? So we took a look at the vasopressin response in our regular and high salt diet fed CFA and saline groups. We saw that in the high salt diet group, especially the response, the PKC response, intracellular PKC release response is actually diminished if they had monoarthritis. And then take a look at the endothelial response as seen with the bradykinin in a regular high salt diet response as well. We saw that with high salt by itself, alongside with systemic inflammation, we saw a loss of endothelial function as seen with bradykinin response in our high salt diet fed CFA groups. That's akin to what we saw with our SHRSP models. And response to nitric oxide synthase inhibition was also lost, particularly with our high salt group with CFA injections itself. So in terms of, those are the functional work that we took a look at with the fact that systemic inflammation also seems to affect cerebrovascular function. And the question being is that now we're seeing this physiological changes to the middle cerebral arteries that lead to cerebrovascular loss and intracerebral hemorrhages. Is there molecular mechanisms that are associated with it? So we then went into trying to take a look at understanding what the molecular mechanisms that could be within the middle cerebral artery itself, and what is the neuroinflammatory conditions in these animals to be able to see whether there's that leads to issues. We moved into looking at basically fluorescence, immunofluorescence and Western blotting. So we basically moved into looking at the middle cerebral artery, not the function, but looking at expressions at this point of PKCs and potentially the vascular, looking at vascular integrity of the animals as well. So we took a look at now the downregulation of contractile signaling. So we saw that the PKC function was lost, right? So that in here, we saw the fact that the response to PKC activation was lost post-stroke. So then our question was, is the active PKC levels there? So when we took a look at the phospho-PKC to total PKC levels, we did a comparison between pre-stroke and post-stroke vessels. We saw that the level of active PKC levels were actually lower in the post-stroke animals, which also is reflective in terms of their function. Our question was vascular integrity. As you know, a lot of people take a look at the fact that the actual extracellular matrices are lost. We look at the inflammatory aspects of MMPs and such. We were actually going back into taking a look at actin levels, okay, because we're actually looking at the physiological structures in cells, and particularly because we're looking at functional contraction and integrity, vascular integrity. We took a look at filamentous actin versus globular actin levels before and after stroke, and also structural proteins amylin-1, which is also involved in TGF-beta signaling as well, and looking at amylin-1 expression before and after stroke itself. So the F-actin to G-actin drop in the post-stroke that you see here, that we took a look at the F-actin G-actin ratio brief before and after stroke. In post-stroke, it means that there's a loss in the middle cerebral artery structural integrity that's available. And the decrease in amylin-1 is also evidence of decrease in vascular integrity after stroke. And that would contribute directly to the extracellular matrix stability. Okay, so with that, the next question, of course, is how is it going to be able to contract? Can we take a look at changes to the myosin light chain levels? And is there any changes to the myosin light chain levels as well? And our thought process was that the phosphomyosin light chain is actually decreased after stroke, and that's why it's not able, the vessels are probably also not able to contract. But what we saw is that post-stroke animals, our phosphorylated myosin light chain was actually increased. So the question is, so why is it that the myosin light chain is actually increased, but the response is actually decreased? We were trying to figure out the link here. And what we are postulating is that the activated myosin light chain is there after stroke. But if you combine that with the fact that there's not enough filamentous actin, that's the active actin to be able to allow to link with the myosin light chain to form cross-bridge cycling in terms of being able to actually contract. The lack of that presence of the filamentous actin, we're not going to be able to see any kind of tension development and contraction of the vessels themselves, middle cerebral arteries themselves as well. So actin polymerization is going to be is a must for actin-myosin cross-bridge cycling. And so even if you have enough myosin light chain there, there's not enough filamentous actin there for it to actually have that tension development that's required for the vessels themselves to react to blood pressure changes and systemically and contract with it. The next question, of course, now is that we're talking about inflammation, and pro-inflammatory signaling was the next question in our post-stroke animals. We took a look at the more basic inflammatory signaling of P38 MAP kinase and p-ERK, phospho-ERK, over total ERK, and we saw that in post-stroke we have an increase in levels of P38, phospho-P38 MAP kinase and phospho-ERK as well. So there is definitely within the middle cerebral arteries themselves, there's an increase in pro-inflammatory signaling that can occur. Is there increase in neuroinflammation around the area of the middle cerebral arteries before and after stroke in our SHRSP models is the question that we asked, and doing very similar neuroinflammatory testing with the SHRSP model, we saw that we actually have an increase in astrogliosis as well as activated microglia. I apologize for the uncrispness of the image here itself. It was pretty crisp before, but I don't see it to be that crisp right now. But we did analysis quantification, semi-quantification with the total inflammatory cell count of the IBA1 and GFAB, which is our astrocyte astrogliosis, and we saw that there was an increase in post-stroke animals around the area of the middle cerebral artery in the brain itself. Okay, so all of this is leading us to understand what can we do really in terms of treatment. And as unconventional as it might be, we thought of potentially antihypertensive treatment that could actually work. So the next question really in terms of hemorrhagic stroke development and treatment options is the fact that, number one, we don't have good treatment options, a bit none, for hemorrhagic stroke itself. And we're seeing that there's inflammatory conditions associated. So can anti-inflammatories be an option? Yes, it could be. Can we actually use potentially current drugs that we have for hypertension, for high blood pressure, and maybe decrease the blood pressure to be able to help with the cerebrovascular loss of function? Are they linked? Can we use antihypertensive and basically see whether there's treatment associated with the antihypertensives? And are there antihypertensives that actually may be considered anti-inflammatory? And interesting enough, angiotensin type 1 receptor antagonists and ACE inhibition, they decrease angiotensin 2 levels, and angiotensin 2 is considered to be almost like a pro-inflammatory mediator at current times as well. So one of the thought processes we had was, can we restore maybe function, cerebrovascular function after hemorrhagic stroke in our animal models using ACE inhibition and angiotensin type 1 antagonists? And what was taken a look at with the group was to be able to see the treatment regimen and experimental summary as you see here. So what we did was we took a look at our SHRSPs. So these are our stroke-prone models. This is where we wanted to test this at this point, is to take a look at our stroke-prone models in which the hemorrhagic stroke indications were very, very intense. They were on the Japanese high-salt diet, a 4% high-salt diet from weaning. We divided them into pre-stroke animals, 10 weeks, and post-stroke animals. And these animals, after we saw first behavioral signs of stroke, they were, we divided them into untreated ones, those that were treated with oral losartan, 35 milligram per kilogram per day, and oral captopril, ACE inhibition, 50 milligram per kilogram per day. We followed them from sampling, in terms of sampling, for 10 weeks prior to stroke development, at stroke, so we sampled them in untreated areas, and after treatment, from the first signs of stroke at 13 days, 33 days, 63 days, or longer, however longer it was. We took a look at mortality curves, systolic blood pressure measurement, blood-brain barrier, permeability studies, cerebral blood flow autoregulation, and assessed the MCA function and response to pressure. So the questions that were asked were, does captopril losartan treatment prolong survival? And you could see here, here's the survival after stroke in terms of percentage and days after stroke. You could see the fact that the post-stroke animals do not actually have any response. They die within, this is 20 days after stroke. So these are non-treated animals. The line here is the captopril survival, and you could see that post-stroke, they actually do survive quite well in captopril. Some of them did survive after about almost 180 days itself. However, with losartan, you could see that a lot of them were able to survive up until 200 days, and then from there, the mortalities increased a little bit more, but often more than not, they could survive 2 years. Some of them were able to survive up to a year. When we took a look at the blood pressure changes, of course, the conditions being, well, can we decrease blood pressure? And that's what's causing the decrease in terms of mortality. We took a look at the blood pressure differences at stroke, captopril losartan treatments, and captopril and losartan. You could see that the blood pressures do not actually change. You could see that at stroke is about 247 millimeters mercury. Systolic captopril is 270, losartan is 243, and the combination did not do anything in terms of decreasing systemic blood pressure. So the increase in survival rate is not because the systemic blood pressure is actually decreasing. So what is actually happening? Let's take a look at the treatment, captopril losartan treatment in terms of blood-brain barrier permeability differences. And here's our infamous pre-stroke, post-stroke SHRSP brains that you've been taking a look at the last while. Let's take a look at the post-stroke SHRSPs 35 days after captopril. You could see that after 35 days, Again, the brain looks just as distorted. It's still edemic, and there is still old hemorrhages available. Evans blue dye extravasation is still occurring, and the brain is not that well vascularized. However, what's interesting is that at 35 days losartan treatment, you could see that dramatic improvement in terms of the brain, in terms of the vascularization. The septum is almost nice and clear. You basically have what you're seeing is you're promoting healing. So you're preventing the breakdown of blood-brain barrier, and you're actually promoting healing, and it seems to be better than captopril itself. Okay, so and that's evidenced by the Evans blue extravasation themselves. The next set of questions is, does captopril losartan treatment restore cerebrovascular function? When we take a look at the pressure-dependent constriction and the PKC-mediated constriction at stroke, and looking at the lumen diameter at stroke with just captopril, with losartan, and captopril plus losartan treatments, you see that the pressure-dependent constriction actually is normalized better with just losartan and with the combination treatments compared to at stroke. And looking at the response to PKC-mediated constriction, again, with losartan and captopril losartan treatments, the improvement in terms of ability of the lumen diameter to get smaller, which is response to PKC, is actually restored much better as well. Captopril, of course, is restored here as well. Taking a look at the response to LNAME, constriction to LNAME inhibition, which is a response to endothelial function as well as non-endothelial NOS function. You could see here's our no treatment before and after stroke. You know that after stroke, the LNAME response is actually diminished in terms of lumen diameter. Looking at the 7-day, 16-day, 25-day, 40-day, 116 and 165 days for post-stroke captopril in black and post-stroke losartan responses in white. You could see at 7 days, the response to LNAME seems to be restored for both treatments. We don't have one for 16 days here for losartan, but for 25 treatments, it's both of them are still maintained. But after 40 days, the response to LNAME is diminished for captopril, whereas it's maintained for losartan up to almost 165 days. It's not, of course, as up to before stroke, but it is maintained better than after just stroke without treatment itself. And last but not least, in terms of the treatment aspects, you could see we took a look at whether autoregulation actually, how does cerebral blood flow autoregulation restored after stroke in SHRSPs after treatments. This is our hockey stick pre-stroke animals and post-stroke, how the autoregulation is lost with our animals. If we take a look at our 13 days, you could see that both captopril and losartan autoregulation, middle cerebral artery autoregulation is somewhat restored compared to the post-stroke animals. It is maintained with 33 days for both captopril and losartan. However, after 63 days, you could see that losartan is able to maintain autoregulation. Here's the hockey stick with the losartan, but with captopril, it is not. It's not evident at all. So, all of this to be able to show you the most dramatic improvement is by video, by looking at them physiologically. So here's a video. It's a bit of an older video. We've been doing this in our respective labs differently. So this is our stroking animal with the SHRSP. You could see this poor fellow has everything. He's not well. He's lethargic. He's twitching. He's not happy. He does not want to move. He's sluggish. He's very puffy. His face is very puffy. This is right after he just got stroke, and he's just and usually, euthanization is the next step for this person if there's no treatment options available. So this is the exact same animal 4 days after post-stroke losartan treatment. This is just in the water. You could see the dramatic improvement in its fur, in its eyes, in its puffiness. It's curious. It's moving around, asking, "What are you doing now? Can I get out and get some apples and some food from you?" No, well, let me see what's going on outside. He's very curious. 17 days post-stroke. Now he's gained a bit of weight here. Same animal, he's gained a bit of weight. He's got a bit of a wobble, but he's still walking around. He's happy, he's curious, he's healthy. None of the twitch and none of the signs and symptoms of stroke are available there. Further studies actually in SMETA lab took a look at behavioral studies and improvements with losartan and captopril to be able to correlate what we see here, physiological symptoms and physical symptoms that we see with these animals with behavioral symptoms as well. So if anything can convince you, is this amazing video, in my opinion, in terms of the benefits of AT1 receptor inhibitions. And I've been wanting to pursue that for, further, as you can see in some of the future directions. So in summary so far, stroke development in SHRSP destroys the ability of the middle cerebral artery to autoregulate, to elicit constriction to pressure and respond to vasogenic agents. Loss of autoregulation to high blood pressure is likely due to loss of myogenic function. In chronic systemic inflammation in a hypertensive animal, it induces MCA dysfunction, neuroinflammation, and stroke. Loss of contractile apparatus and increasing inflammatory signaling in middle cerebral arteries is partial mechanisms, and myogenic dysfunction and pressure-dependent constriction of the MCAs of the post-strokes were reversed by both captopril and losartan, in the absence of the antihypertensive effect that we anticipated. So our future directions really is to be able to use different types of imaging technology to be able to ask further questions. So we want to be able to take a look at the imaging alterations that can occur with the vascular branching and intercerebral hemorrhage. And with work that we've been doing with our colleague at U of A, we've been taking a look at the use of microcomputer tomography coupled with bundle analysis software that can produce 3D constructions of vascular network at a resolution that's sufficient to resolve small blood vessels and have the tissue intact so we could do subsequent immunofluorescence analysis itself. So as you may well know, soft tissues like cerebral blood vessels are not easily detected by X-ray modalities such as micro-CT under normal conditions. But when we actually fill it with a radio-opaque contrast dye, like bismuth silicone bismuth material that we've purchased with work with Medilumine, the vessels can actually be visualized by micro-CT. So our objective so far right now has been to establish a methodology to define changes in neurovascular network parameters. And those are such as volume and connectivity in our animal brains before and after stroke, and then see what happens after treatment using this high resolution imaging technology itself. And so far, it's this early work so far, but what we've done is once we infuse our brains before and after stroke with this Vascupaint, which is a bismuth material, this bismuth vanadate, we could macroscopically see the vessels actually light up here in yellow. And when we image it using micro-CT, using an exposure time of 300 milliseconds, we can actually scan the entire brain. And this is a 9-micron resolution, which we've actually used the NRECON program to create slices, about 2,500 axial slices of each brain. And here is basically a MIP maximum intensity projection of the brain using this Vascupaint before stroke and after stroke. What we do is we take a region of interest and then we analyze the region of interest. It's around the middle cerebral artery area and around the area of stroke, and we try to analyze the level of the connectivity and the vascular intensity as well. And what's interesting is that we could actually take a look at, this is my colleague actually produces, this is fantastic. With our brains, this is one of our pre-stroke brains. What we can do is actually do a 3D projection of what the brain looks like after micro-CT imaging. And you could see that this is our vessels, this is our brains on Vascupaint. And I like to be able to see our vessels on drugs and see what happens with our vessels and imaging with this new modality that we have available to us. So thank you for bearing with our presentation, I have a lot of people to acknowledge. My research team is fantastic, and my collaborators are just as fantastic to be able to work with us with the research itself. It's pretty amazing in terms of what we can do with the modalities that we have, and I'd like to thank Synteca for the opportunity to be able to present. And I'm going to pass the presentation back to Gabriel for any kind of questions and answers. Thank you.
Thank you, Dr. Noriko, for the presentation. Fortunately, we have reached the 60-minute mark for our session today, and to be respectful of everyone's time, we're going to wrap things up. However, I want to let everyone know that as mentioned at the start of the webinar, we will be sure to answer any of the questions that are written in the transcript, and we'll work to get this out to you over the next few days. First of all, I would like to thank Dr. Noriko Dineshla for the great presentation today, and I trust that we have been able to provide you with a better understanding of the different modalities to study mechanisms of hemorrhagic stroke in a rat model. If in the days and weeks to come you have further questions about the modalities discussed today, I encourage you to reach out to us here at Synteca, and we'll be happy to help you. Thanks again to all of you for taking time out of your day to attend our session, and we look forward to seeing you at a future Synteca event. Have a great day.